Good afternoon, everybody. My name is Councilman Isaac Gitzi-Schleifer, Chair of the committee. To my left is Council President Zeke Cohn.
Thank you, Mr. Chair.
To his left is Vice Chair of the committee, Councilman Glover. And to my right is Councilman Gray. The reason for this hearing is LO 25-0037, opioid epidemic response. Thank you to the commissioner for voluntarily coming here. This is in follow-up to a previous hearing that we had. There's some questions around what would be your plan towards the opioid response. And instead of just giving us an answer, you said, give me some time to formulate what that looks like, what the plan looks like, and a proper answer, which we appreciate. And so here we are to hear that. And so if you can just introduce your team and then go into your presentation. Thank you.
Absolutely. Thank you, Chair Schleifer. Dr. Michelle Taylor, Commissioner of Health for Baltimore City. To my right is Julia Roche, part of our Legislative Affairs team, and you see several people from Baltimore City Health Department here in the chambers today. Can we get started? All right. Good afternoon, Chair Schleifer and members of the committee. Thank you for providing this opportunity for me to share my vision for Baltimore City Health Department's role in addressing the opioid crisis. Next slide. Today's presentation will begin with an overview about the city's behavioral health ecosystem, a brief overview of the citywide overdose response strategic plan developed by the Mayor's Office of Overdose Response, and a brief overview of the needs assessment led by the Baltimore City Health Department that informed the strategic plan. We'll then discuss Baltimore City Health Department's new division of public behavioral health, as well as new programming within our other divisions, my vision for our work, and the city's new mass overdose rapid response protocol. We'll close with our next steps and key priorities. Next slide. We'll start with some very brief background and overview. Next slide. This is a slide some of you have seen before. It shows the major pieces of the behavioral health ecosystem in Baltimore City. I think it's important to start with this to ground us in how Baltimore City Health Department's programs and services, including but not limited to our new division, are part of a greater system. Above everything, we have the state, specifically the Maryland Department of Health. The state sets regulations and is responsible for licensure, oversight, and funding of behavioral health providers. On the left, below the state, we have Behavioral Health System Baltimore. BHSB is a nonprofit organization that serves as the city's local behavioral health authority. They manage the city's public behavioral health system, support the state with oversight and provider accountability, and administer state and federal funding to community-based organizations. As Health Commissioner, I chair their board. On the right, we have the city administration and various offices and agencies that coordinate and provide behavioral health-related programming and services. This includes health, the police department, the fire department, and the Mayor's Office of Overdose Response, also called BC More. BC More coordinates the activities of city agencies, chairs the Mayor's Overdose Cabinet, and co-chairs the Restitution Advisory Board. They also led the development of the city's Overdose Response Strategic Plan, which I will touch on in a moment. I see Baltimore City Health Department as being a service provider, a partner, a strategic collaborator, and a leader working at the nexus of state and local government, non-governmental, and community-based organizations to ensure that programs are effective, responsive to community needs, and efficient. Next slide. Before I came to Baltimore, Baltimore City Health Department conducted a citywide overdose needs assessment. We're actually gearing up to do another one this spring, as the Mayor's executive order requires that a needs assessment be conducted every 2 years. Our last assessment included both qualitative and quantitative data collected through a variety of methods. You can scan the QR code on this slide if you'd like to review our needs assessment dashboard after this hearing. Next slide. The needs assessment informed the creation of an overdose response strategic plan for the city, led by the Mayor's Office of Overdose Response and published in July 2025 for public comment. The plan provides a framework for the next 2 years of work and sets a goal of reducing overdose deaths by 40% by 2040. The plan is organized under 5 priorities with 13 strategies and 47 targeted activities that will move us toward that goal. Many of the strategies and activities involve Baltimore City Health Department, but the strategy is bigger than just one agency. Baltimore City Health Department and other agencies are working in close partnership with BC Moore to ensure implementation and execution of the plan. Next slide. Now, I'll shift to discussing what we're working on at the Health Department in terms of reorganizing and ramping up our behavioral health work. Central to this is the creation of our new Division of Public Behavioral Health. Baltimore City Health Department's behavioral health work touches the whole lifespan, ranging from pregnancy through older adulthood. Recognizing that overdose is the leading cause of maternal mortality in Maryland and that overdose deeply impacts our older adult population, we've also added programming in our Bureau of Maternal and Child Health and our Division of Aging and Community Support. I'll talk about these programs in the upcoming slides too. Next slide. On this slide, we show our behavioral health work across a public health framework called the Health Impact Pyramid. Our activities range from the macro level to the individual level, including working to change policies and systems, improving community contexts, increasing providers' capacity to support people who use drugs, and providing high-quality services to individuals. Next slide. The creation of the new division began in 2024 when Baltimore City Health Department put forward a proposal to the Mayor's Office for how the agency would use opioid restitution funds to stand up a new division. Based on that proposal, the core functions of the new division are data and epidemiology, policy and strategy, communications, and essential services. Next slide. Here is a way to visualize just some of the activities we're doing. This is not an organizational chart. Rather, it shows the various categories for this work to illustrate the public health approach we are taking. We're working to address substance use disorder holistically, working across prevention, harm reduction, and treatment. We also have several programs and initiatives that connect people with the social supports they need to be healthy. While the slide shows the social determinants of health as a distinct section, this work can be thought of as a component of prevention, harm reduction, treatment, and recovery because these resources are essential to our overall well-being. In alignment with our proposal to the Mayor's Office, our programmatic work is driven by data, with a robust epidemiology team providing data analysis and evaluation. This is coupled with a policy and strategy team who partner with our epidemiologists and other teams to ensure our programs and initiatives are rooted in evidence and responsive to residents' needs. This work would not be complete without a communications arm. We're collaborating with Charm TV to develop a communications campaign and are hiring a dedicated communications specialist to lead our efforts internally. The programs and initiatives in the light blue boxes have been expanded, and the programs in dark blue have been launched since I was sworn in. Next slide. Let's see, make sure I'm in the right place. My vision for behavioral health in Baltimore City is a comprehensive and integrated system that reduces barriers to care and amplifies a no wrong door approach. While the Baltimore City Health Department has a strong history of harm reduction programming, we have room to grow in prevention, treatment, recovery, and addressing the social determinants of health. While we have historically touched on these areas, for example, through our Kids Off Drugs programs, the Healthcare on the Spot mobile BUPE clinic, and referrals to social supports through the Spot and our syringe services program, we have significant opportunity to grow here. We're actively exploring multiple ways to build up our programming in these areas, including, for example, increasing medical street-based outreach, combating stigma around medication for opioid use disorder through a communications campaign, providing group-based support for people who have lost loved ones to overdose, and hiring a youth prevention coordinator to focus on increasing our work in schools. These are just some of the new activities we are exploring. I'm eager to continue working internally and with our partners to reimagine and expand how we approach behavioral health. Next slide. Let me walk you through some of the challenges and gaps we've identified using a public health lens. There are many known barriers at the policy and systems level. For example, the illegality of overdose prevention centers and criminalization of drug paraphernalia. Something we hear directly from community members is that they are afraid to engage with our syringe services program because they are worried about being stopped by police while in possession of syringes. While syringe service programs are legal and registered clients are protected from being found guilty of violating paraphernalia laws if they're found in possession of syringes obtained from SSPs, syringes are still criminalized paraphernalia. This is a serious problem because it deters people from engaging with SSPs. Not only do syringe service programs provide access to important care and services, they are also proven to lead to clients entering into treatment. According to the CDC, SSP participants are 5 times more likely to enter drug treatment and 2.5 times more likely to stop using injection drugs. Clearly, this is something we need to address. I'm pleased to share that decriminalizing paraphernalia is once again a mayoral priority for the upcoming state legislative session. A major issue at the community level, which is the next level you see on the pyramid, is stigma. In particular, stigma related to medication for opioid use disorder and stigma about accessing harm reduction services. We need people to feel they can access any services they want or need without shame or fear of being stigmatized by their communities. We've identified several gaps at the clinical level. For example, lack of availability of medication for the treatment of opioid use disorder and stigma among providers. We're planning several initiatives to address these gaps and more, including engaging pharmacists to stock medication for the treatment of opioid use disorder, and training experienced doulas to better serve city residents who are actively using substances or who are in their journey of treatment or recovery. We are also working on incorporating academic detailing programming at the health department. Academic detailing is training for providers regarding prescribing practices, culturally competent care, and reducing stigma. I also want to recognize that behavioral health is much broader than substance use or overdose. It also includes mental health. In order to ensure that families can thrive, we must look at the larger spectrum of needs, including addressing trauma, grief, and the social determinants of health, like housing, food, and financial stability. As I mentioned a few minutes ago, this is an area where we have room to grow. As soon as our deputy commissioner is onboarded, one of my asks will be to assess our portfolio with an eye on how we can better address these needs. Next slide. Here is the organizational chart for our new division. As you can see, we have 3 offices: administration, overdose policy and strategy, and community risk reduction services, all overseen by a deputy commissioner. We also have Healthcare on the Spot, our mobile bupe clinic that we run in partnership with Johns Hopkins. While we have been doing this work for a long time, this was previously a much smaller team. Now that we have the influx of opioid restitution funding, we can create a more robust team to address the needs that have existed for a long time. Notably, funding from these positions comes from a variety of sources, including state funds, federal funds, and the ORF. Next slide. As I already mentioned, we've also added behavioral health programming to the Division of Aging and Community Support and our Bureau of Maternal and Child Health. In our Division of Aging, we're actively recruiting for 2 community health educators and currently onboarding 1 community health educator and a program manager who will provide outreach and education related to substance use disorder, including overdose prevention and access to treatment. Additionally, our home visiting staff, including nurses and case managers, are now hand-delivering naloxone to older adults and individuals with disabilities in their homes. They are also bringing resources and information not only about our programs and services, but about behavioral health services offered by partner organizations. This is crucial because these are individuals who often face barriers accessing these kinds of resources outside of their homes. Next slide. The new prenatal to 3 behavioral health unit within our Bureau of Maternal and Child Health is dedicated to seeing pregnant people, early parenting families, and children through age 3 flourish even when facing substance use and mental health challenges. Our programs for this population focus on overdose prevention and education, sexual and reproductive health for people with histories of substance use, and networking and resources for providers working at the intersection of perinatal health and behavioral health. Next slide. We've hired 8 positions and have 11 offers pending, including the Deputy Commissioner. 3 positions are in the interview process. Next slide. Now I'll shift to discussing another important thing we've been working on, developing a mass overdose rapid response protocol. Next slide. As you all know, the city has experienced multiple mass overdose incidents in the past few months, making it clear that we needed an official mass overdose rapid response protocol. Baltimore City Health Department began developing the protocol in July, immediately after the July 10th mass overdose incident in Penn North. The timeline on this slide shows a high-level overview of the various events that informed the creation of the protocol from July to December. This work culminated on December 2nd, when all agency representatives working on the protocol met in person to finalize recommendations and resolve questions. Next slide. The objectives of the protocol are as follows. Number 1, immediate response and life-saving measures. This includes scene safety and security, rapid assessment and triage, administration of naloxone and medical intervention, and transport and medical surge management. 2, public health service delivery. The protocol aims to reduce overdose fatalities through education and naloxone saturation. It also aims to expand other harm reduction efforts, analyze and share public health data, improve access to prevention, treatment, and recovery services, and combat stigma. And last but not least, partnership and collaboration. The protocol emphasizes including trusted community partners in outreach response work and aims to enhance public health and public safety collaboration. This is exemplified in a unified command structure with Baltimore City Health Department and BPD serving as Joint Incident Command. Next slide. The protocol outlines a scalable, 2-tiered activation structure designed to coordinate timely and effective response efforts based on the severity and scope of a suspected or confirmed mass overdose incident. The 2 levels of activation are partial and full. Partial activation will be triggered by 5 to 10 overdoses, and full activation will be triggered by 11 or more overdoses. The Baltimore City Fire Department will monitor conditions in the field and notify the health department whenever they respond to 5 or more overdoses within a 1 to 3 hour period. The Commissioner of Health or their designee will activate the plan. These activation levels are determined by real-time data and on-scene reports and provide a framework for situational assessment, communication, and operational coordination among response partners. Crucially, I want to emphasize that we are proactively and constantly conducting public health surveillance, monitoring, and reporting to prevent mass overdose events. These are core public health activities, and we have epidemiologists dedicated to that work. Next slide. The response will use the Incident Command System, also known as ICS, which is the national standard for emergency response operations. During a partial activation, the Health Department will lead the response with support from BC Moore, the Fire Department, OEM, and BPD. Much of the response activity will occur within the operations section, which will include a triage, treatment and transport branch, a medical monitoring branch, and a field coordination site to organize outreach and other services. Next slide. For a full activation, we will implement a unified command structure. In this scenario, both the Health Department and BPD will jointly lead the response. The same core services will be provided with the City Emergency Operations Center activated to coordinate resources and support operations. Both activation levels involve a high degree of coordination among participating agencies. Next slide. After activation has concluded, we will move into the recovery stage. At this point, the incident commander will transition community outreach and support to Monsi, who will lead long-term goal development with technical support from BC Moore and the Health Department. While Monsi's subject matter expertise is around violence prevention, they lead citywide efforts to address stabilization and long-term engagement after traumatic events. As with any ICS activation, we will conduct a hot wash after deactivation. Hot washes identify strengths and areas for improvement experienced during an incident and provide important insights for revising and improving the protocol. Next slide. To close us out, I'll touch briefly on our next steps and priorities. Next slide. Our next steps fall into 3 buckets: staffing, planning, and programming. For staffing, we're actively working on hiring the remaining staff for our new division and programs within maternal and child health and aging. This includes the Deputy Commissioner, who will oversee the division. As mentioned, we'll soon be starting the next needs assessment as required by the Mayor's executive order. We'll also be conducting a tabletop exercise to ensure we're ready to implement the mass overdose rapid response protocol. Of course, we will also be monitoring our programming to ensure effectiveness and accountability and support continuous quality improvement. Next slide. And that is it for my presentation. Thank you so much for allowing me to share this information with you today and to give you my insights 5 months into my tenure as your new health commissioner. I'm happy to take any questions you have.
Thank you, Commissioner, for the presentation. Before we get into questions, I didn't see what the numbers that we ended 2025 on. So how many lives were lost to opioids in 2025?
So let me point this out. The 2025 numbers have not been finalized, but so far this year, we have had 500 fatal drug and alcohol overdoses that have been reported for the city by the state, but these data are incomplete because the data lags. But what I will tell you is that in 2023, there were 1,043 fatal drug and alcohol overdoses in Baltimore City. Preliminary data for 2024 show there was 777 fatal overdoses, which represents a 26% decrease. And so once we get the finalized 2025 numbers, we are anticipating that we will have another decrease in numbers. And I believe you just got the information, the one-pager about the data.
Yes, perfect. Thank you for that. You know, one of the things that we discussed at the previous hearing was regarding this goal of the 40% by 2024, and just trying to get some clarity on that. And so what is that based off of? And I'm looking at this chart. Is that based off of 2024?
Well, what I will tell you is it's not just based off of that. And, you know, with public health, it's a number of things. Of course, I wasn't here yet when that number was decided, But I have been informed that there were numerous conversations between the mayor's office, the health department, and there was extensive research done about best practices in other jurisdictions to reach that number. The epidemiologists were involved at that level and had those conversations between themselves, BC Moore, and the mayor's office to make sure that they arrived at a number that was realistic. Now, I say all that to say, we can amend that number, and the plan was always to amend that number if it looked like we needed to be even more ambitious in our goal. But it was based off of looking at other jurisdictions, best practices, and extensive conversations with the health department, the mayor's office, and BC Moore.
And so that was after the 2024 numbers?
I don't know if it was before or after, but what I will tell you is you always have to be careful with data. You cannot base those types of decisions off of 1 year. But what I would say, without having been in the room, is that you had a lot of smart people in the room, a lot of experts, especially the epidemiologists, to say, listen, we anticipate some decreases. Let's do something that's realistic with the understanding that that can change. And the encouraging thing is we have seen a 26% decrease, and we're anticipating even more decreases. Right. So what's the foundation that has been laid and the work that has been done so far appears to be working, and we will continue to expand. And I have been blessed to be put in this role, see everything that's been done, and I can tell you after 5 months that there has been an extensive amount of work that's been done, and everybody has been very patient with me. Anybody in this room who has had to deal with me, and I'll say it that way, has had to deal with my, what I call, mountain of questions. I have questioned them up and down about what went into the plan, why it was done, what they were thinking, what went well, what didn't go so well, right? And I will tell you that an extensive amount of work has been done to get to this point.
All right, so I guess we have that in common. We both have a lot of questions. So again, like that's why I think that when we're talking about, this 40% number, sure, it's important, at least for the council, to understand, from when to when, what those numbers look like, and like right, how much you're looking at on an annual basis, right? So that if we, when we come back next year, like, what are we expecting to see happen? Obviously, absolutely, we all hope that the numbers continue to decrease, but if they're not decreasing, or they are decreasing just not at a certain level, we just want to know what that is so that we could, we can stay on top of that data. So if we can absolutely just try to get some of that information about those numbers and what it looks like on an annual basis, because when you see, from 2023 to 2025, it's decreasing over 50%. Clearly, 40% by 2040 doesn't make much sense, because we can obviously do better than that.
And I understand. I understand your question. What I will tell you is this: as with any other public health issue that you're dealing with, you always want to start with a reasonable goal, but then you always want to reevaluate. So I'll give you an example outside of what we're talking about here. Vaccines, because that's in the news right now, right? We get a different flu vaccine every year. And it has a different level of effectiveness based off of what happened with flu the year before. But what we do know is every year we have a flu vaccine that works for the majority of the people, right? And even if they get flu after getting the flu vaccine, they are less likely to be ill enough to go to the hospital when they have that vaccine on board, right? So that's also my reminder for you all to get your flu vaccine if you haven't gotten it. But I will tell you that that is how public health works. That's also why we have, especially during the global pandemic, people able to insert uncertainty, because data is what's required, and you're always reevaluating. The best jurisdictions do that really well, and I believe Baltimore is in a position to do that as well.
Gotcha. Thank you for that. And my last thing on this topic, and then we'll move on to the rest of the questions. So being from where we are in 2025, seeing to the end of 2026, what percentage reduction are you hoping to achieve between now and 2026 based off of all the initiatives that you have going on to reduce the numbers?
Well, what I will tell you is this, I'm not going to give you an exact number, but what I will tell you is that we are evaluating currently how much of a reduction we expect to see. We are hoping that it will be at least 10%, but, and I've said this to you before, we're still dealing with individuals with a chronic condition that can go either way. But I do say this, the foundation that's been laid, the naloxone distribution, the increased awareness, the communications campaigns that have already happened and that are being developed, I anticipate that we're going to see more decreases to come, and that you will be happy when we're able to amend that number to say that we're going to reduce by even more.
Gotcha. Okay, thank you. Council President Cohen.
Thank you, Chairman Schleifer. Thank you, Commissioner. I first want to thank and commend you for the work that went into this plan. It reflects a substantial amount of effort in 5 months, and have appreciated the way you've moved in the city and the conversations that you've been having all over East, West, North, South Baltimore. A few things. One, I didn't see mention of peers in this presentation. I think that's one of the things that Baltimore does well when we think about some of our violence interruption models, when we think about having peer navigators in our library system. So why not include peers as part of your strategy here?
And I will tell you that peers are in the strategy. Even if you didn't see it, the peers are there. Okay. You saw that slide with the multiple boxes. That includes peers. There actually is a law, I believe it's called the STOP Act, that requires that hospitals have peers in their ERs. And so really that peer model is very much in play. And we are looking at the health department to expand that peer model to really challenge the hospitals to do more in the peer space, to have those folks in the ED, not just past the minimum of having them available by law, but really expanding that program because we know peers are so effective. So yes, it is included in the strategy.
Great. Yeah, and I would like to see even more emphasis. I think that it's evidence-based. It's, yes. You know, we know that folks with lived experience with this disease often have really good skills to be able to support other people who are struggling. I think the other thing that I wanted to lift up is I am thrilled by the speed at which you're moving to create the Division of Behavioral Health, as I've discussed with you pretty extensively, as well as with your predecessor, who I see, hello, Dr. Jarasa. I think it is critically important that Baltimore continue to be a leader in the space of behavioral health nationally, and even internationally. And I think we have been in the past, and I think we have many skills and tools, but this is so important, having that framework, having so that we're not just relying on partners to do the work, right, but we are we have our own office, division, et cetera, set up in place. I hope that moves very fast. I saw you're hiring 8 folks, I think, for that.
That's right.
And then a deputy commissioner. Talk just a little bit more about your expectations of what exactly that division will do.
So initially, that division was stood up to really focus on addressing opioids in the community and addressing folks who are struggling with substance use disorder. But long term, and this is something that I've been saying since my first week on the job, we know that behavioral health is so much more than that. And so that's why we have moved so fast to hire these positions so that we can get to the focus of what the division was originally designed to do, but to also to start to reimagine what else we can do with this within this division. You and I have had multiple conversations around the fact that a lot of what we're seeing in our community around behavioral health issues has to do with trauma. And so we are really thinking across the lifespan about how we address trauma at every stage and age of life. And you see that in the plan that we've put together. But at the same time, we understand that we have to be able to sustain this past ORF funds. And so that's why I believe that, this has been such a good 5 months because the team has worked really rapidly to meet the expectations that I've put in front of them. When we first started talking about this division, there was a lot of questions around how are we going to get this done? And I tried to reassure the team that not only can we get this done, but you have all the pieces that you need to make this successful. It's not just about getting it done, it's about making it successful and doing it efficiently. So we're being very good stewards of the funding that we've been given, while also looking at every possible avenue to sustain this division and to think about what other things we need to be infusing into the community that we haven't done already. And so, as you know, that takes time, but I'm super proud of this team and everything that we've accomplished so far.
I appreciate that. I'm going to conclude with just 2 remarks. One is, again, I appreciate the seriousness with which you took this assignment. This plan is robust and comprehensive, and I appreciate it. I'm looking forward to when I go home tonight, digging even deeper and doing the reading. So appreciate that. I'm going to concur with some of the sentiment my colleague was expressing around, I don't think 40% by 2040 is the number. I think Baltimore is better than that. I think that we have shown over the last couple of years with tremendous reductions in violence that we can beat expectations substantially. We already see this trend where the deaths from overdose are going down in our city. And so I would encourage you and the team, make it your number, right? I mean, whoever wrote that before, appreciate all the work that went into it, but you have an opportunity. You are the health commissioner. I think what this council would love to see is what is a realistic stretch goal where if we are operating on all cylinders, if this division is stood up, if we are working across all of our agencies and with partners and with community, how many lives can we realistically save in our city?
Absolutely.
And so I think that's my last piece of feedback for you is that I think that Councilman Schleifer, Chairman Schleifer is right to push, and that we and you have an opportunity to do better when it comes to and I would even take a look at the time span because I think it's a long time between now and 2040. And so what can we, how can we benchmark 5 years out? How can we benchmark 3 years out? I would love to see you come back with even a sharper and more precise analysis of what we can get to. That said, really appreciate the work that went into this plan.
I appreciate the challenge and we will rise to meet it.
Thank you.
Vice Chair.
Thank you, Mr. Chair. Thank you, Director. So my question is, we know that we're now been put in a situation where there's a lot of smoke shops coming to our community, right? And that's been one of my biggest topics, from 25, and then we're bringing it to 2026, and a lot of my colleagues as well. What I fear, and I see that we have plans on reducing to 40%, by 2040. But what I'm also witnessing is that the young people that are now going to the smoke shop, that are purchasing the marijuanas and the other drugs that are, some of us don't even know what the heck name it is, but they're going into these smoke shops and buying these drugs. My fear is now, how do we attack that? Because that's the next generation of addicts that I see in our community, right? And how do we put our hands on those young people with engagement, services provided? Because what I'm saying now is a lot of homelessness is coming from behind it, and now they're chasing that other drug.
Right.
Right, and I see them all down my Union Street. They're chasing a drug to get them to a point where the marijuana may have calmed them down and things of the nature, but now they're going to maybe the fentanyl, things of the nature. I mean, it's happening. I'm getting, inbox on social media from parents saying, I don't know what the heck my son has taken or what they've sold my son, but we're in Hopkins right now, and we don't know if it's a life or death situation. So that's what I feel right now. And how can you help, address those issues as we move forward in the next coming months, year? Thank you.
Thank you. Great question. And I will tell you that the team and I, in preparation for this, we talked about this. So in my opinion, it's twofold. One is it's an enhanced communications campaign where we're not just focusing on opioids, but we're focusing on all of the other substances, like you said, some that we don't even know the name of, so that we are making not only kids aware, but their parents aware and their families aware. The other piece of that is really enhancing what we're already doing in schools and expanding that. We know that there are substances that are being introduced to our young people at earlier ages. But we also know that we have a unique opportunity with our schools to really get in there and talk to them about these substances early. And that's where that prevention piece comes in. In the presentation, I talked about places where we have room to grow. That's one of the major areas we intend to grow. And we already have the foundation within the health department with our tobacco program to grow that even further. So I appreciate the question, and you will see that we will be expanding programming and introducing some new communications to make sure that we're reaching those families and that they're not ending up in the hospital the first time they hear about these substances.
Thank you, Dr. Taylor. I appreciate that. And if you need, my help, my assistance, that we're there to partner with you guys. I mean, if you need to talk to some young people in our community, they're willing to talk, to you guys. And they're wide open. They're going to tell you like it is. And they're going to be truthfully and honest up front with you guys. But I can say I'm starting to see it happen, particularly into much dangerous drugs.
Right.
And I think we just need to get our hands on it like right away before it expands to get any worse.
And that's why we're looking at hiring a youth prevention specialist,
Yes.
because we know, like you said, we've got to hear it from these kids. I just turned 50. I don't know everything that's out there. I drive my daughter crazy, who is 11, because I am like, you can't even go to the corner store because I don't know what they're selling, right? And that's what parents and families are dealing with every single day. But if we can advise these children and advise these parents early, then we can prevent a lot of this.
Yeah, I agree. Yeah. Thank you. Thank you, Mr. Chair.
Councilman Conway.
I have a question.
You guys want to rock, paper, scissors for it? All right, go ahead. Great.
Thank you, Chair, and thank you, Dr. Taylor, and to the Health Department for, as my colleagues has mentioned before, this robust plan and just the presentation overall. I just have a quick question about the opioid response, in particular the full activation.
Yes.
And I guess partial as well. At the end of the day, it seems like it's being informed by the fire department and the activation of the health department for partial. And then for the full activation, it's a unified command jointly by the health department and BPD. Where does the buck stop if there's a disagreement? That's the first part of the question. And then I'll ask the second one.
Okay, all right. Great question. So in a unified command, really the buck stops with both organizations, but just from my past experience, what ends up happening is it really is a unified command. The police will inform, based on what their investigation is, what we are able to do as a health department and not. All of the agencies came together to really sit down in person and discuss what this looks like. So we had robust conversations about exactly what you just asked. Where does the buck stop? Who is responsible for what? Who's going to make the call when we have to do this full activation versus a partial activation? The one thing to understand is this: the monitoring that goes into this, underlying all of this, is constantly going on. Even now, the fire department hooks into the health department, and we are able to see in real time when there are overdoses in the city each day. What we had to decide is, you know, unfortunately, there are multiple overdoses every day in the city. But what we had to decide is, if there are so many within a very defined period of time, who makes the call, right? So we had that discussion, but also we knew that because of the lessons learned from the past mass overdoses, we knew that the police department needed to be in unified command because they do an investigation after all of these mass overdoses, to the point where we can't even release a health alert about whatever substances were in the drug supply until we consult with the police department so that we don't affect their investigation. So when I say that it's a unified command and the buck stops with both of us, it really does.
Thank you for the answer, because in looking at the chart, my second question was, could you walk me through, and you kind of did, why BPD is the unified command and not maybe OEM or the fire department. When you look at the chart, there's only one area, which is security for BPD, where there are multiple agency assignments for the health department, fire department, and then you have the EOC manager being the the Office of Emergency Management. So to me, I was just unclear of why the uniform command would be with the health department and BPD, when in the plan it looks like they play a smaller role as opposed to some of the other departments, such as the fire department or OEM. And so I think you kind of explained it, but if there's any more that you could to help me think through
Sure.
that, I would be more than happy.
Well,
Here.
you know what? You brought up OEM, right? And so remember that the city's emergency operations plan, so we had to consider all the other plans in the city as well, to include the mass casualty plan on the fire side and the city's emergency plans. But it designates the health department as the lead agency for public health and medical services, which is, you know, in technical terms, function H. So because of that designation and the framework that we tried to put together, and because it's multi-agency, we felt like it needed to be that way. But we were also super detailed in the assignments so that everybody could be clear on what their role is. This does not negate the emergency operations plan. It does not negate the mass casualty plan, but it augments that for this particular situation, which really is a public health emergency.
Thank you.
Councilman Conway?
Thank you, Mr. Chair. Good to see you, Commissioner, and hope everything's going well and that you're fully in the agency, and appreciate your continued efforts here. I have two pretty straightforward questions. I tend to think about this issue systematically and how people progress through the system. Of course, in chairing the Public Safety Committee, I still think about our emergency responders. One of the bills I put forward was around buprenorphine. I'm curious if there is an intention or any discussion about the expansion of the distribution of buprenorphine using paramedics. Is that something you've discussed at all with the fire department?
We have discussed that as a team. We know that that's something that, you know, is being debated at the state level as well. It is not a hard and fast no, but just like this mass overdose response plan, it's something that we have to consult with all of our partner agencies across the city to make sure that we are in alignment when it comes to starting something like that, so that everybody knows where the responsibility lies. And like you said, when you have an individual working through the system, that they don't fall through the cracks, right? So I could say as a health commissioner that I want to start this program, but if the fire department is not ready to be able to administer it, maybe their people aren't trained, or maybe they don't feel comfortable with it, or maybe, they're too task saturated to do this and everything else that they do, then it would be irresponsible for me to say, just start the program, right? But we have had discussions, and there's nothing to keep us as city agencies to really talk about it, plan it, and do it in a way that's actually going to save lives and start people down the road to treatment and recovery.
So is it safe to say there is a desire to do it, but the question is figuring out the logistics?
What I can say is that there are discussions about it. Desire may be a strong word, because I don't want to put words in people's mouths, but
Sure.
there are discussions.
I appreciate that. Thank you. The follow-up question to that is, once again, thinking about systems. Just a couple hours ago, I went to go visit a residential treatment center just outside my district, literally right across the street from my district. And I was talking with the folks who are part of the center about their experience, and the issue that came up was multifold. Probably the most memorable for me was quality. The quality of treatment centers around the city. And my thought here is you have an overdose, you respond with naloxone, which is increasingly available as we distribute it as freely as possible. That person's in withdrawal, we could theoretically respond with buprenorphine if we're able to actually figure out the logistics on that. The very next step for that person would be to refer them to treatment if they are ready to take that next step. The problem is, when I was talking with folks and we were talking about exactly the idea, a lot of the treatment centers are not that great. I'm curious if the department is collecting, thinking about, noodling on, musing about, I can go on for days, quality and how we assess quality in that next step, because we all know, I think because we are distributing naloxone more frequently, we're going to see deaths go down, but addiction is still a problem. If we are unable to address addiction, you keep rolling this issue up. You have to address the deaths. Once you address the deaths, then you have to address addiction. Once you address addiction, then you have to address trauma and poverty and all those other issues. But you have to move up the ladder. And we're still in the ladder that is very much in the health department's expertise. What are we doing about quality of care? How are we assessing the quality of options after we've got someone that comes as a referral or gets an emergency response from either the police department or the fire department or EMS?
So, Councilman Conway, I'm glad you're asking that question. I actually had a meeting with our trade organization in the state, Community Behavioral Health Association, and was asking that exact same question. And we literally, in the course of the meeting, had the whiteboard open and were mapping out what the system looks like from my mountain of questions for that meeting, right? So, to your point, yes, we are noodling on it. Yes, we are asking, who is the keeper of the list? Yeah. Right? And what they explained in that meeting in particular was, yes, there is a list, but it's a varied list. It depends on what they do in the treatment center. It depends on how many people they can serve. It depends on what they're trying to address, right? All of those things. But my goal, and I'm waiting for this deputy commissioner, I'm hoping this person accepts our offer, is that will be one of their key priorities within the division, to really get at the crux of that, understanding that a lot of that oversight piece is a state role. And, I have to keep reminding you all of that, because the Baltimore City Health Department, while I wish we could do everything, right? There are certain oversight pieces that live within the state, and they should, right? And so we will definitely work with Maryland Department of Health to find out who's operating in the city. What does that list really look like? What makes that list diverse? And also continue to push on quality assurance and quality improvement, because those are important. Like you said, if somebody travels through the system, the last thing you want is for somebody to be ready for treatment and then they
And not
go
get the quality.
and it is not what they need.
Right.
That's the last thing you want.
Right.
And so we really have to assess that as well, and we are thinking thoughtfully and intentionally about that at the health department.
Yeah, I appreciate that, and I'm glad you're already thinking about that and trying to figure out how to resolve it. I think this is something I've been noodling on for the last year, and it was in the suite of policy recommendations that I gave to the administration, this was probably one of my top three. Whatever we could do to help quantify or qualify the quality service that different providers provide. So if I know you guys are working with the state on this matter, I know they're having difficulties trying to figure out how to assess the good from the bad. If you guys have data or information that might help them refine state law on what data that providers must collect, I think that'll go a long way. And I don't know if you guys are already doing that, but I would highly recommend it. Because I would say in Baltimore, we have a lot of these experiences and can learn a lot because we see it so often. And I think we have an opportunity to direct the rest of the state by what we've learned in the last year. So just appreciate you to that effect. I think I would love to have an opportunity to sit down one-on-one with you and talk more about some of the things I think we should be doing and really understand what we're already doing. I think, I would say this is probably our highest priority as a city right now to effectively address this issue, and I appreciate your leadership on it. So,
Absolutely.
Thank you.
Thank you, Councilman. Commissioner, can you just elaborate a little more? You presented the new organization charts, so it's the first time we're seeing those. Are those new positions, are they just reclassified of current positions that you guys have, or are they actually going to be newly created positions that you're going to be seeking funding for in the next budget year?
Great question. It's a mix. So some of them are new positions that were created. Some of them are reclassified positions, especially the ones that were created for our Maternal and Child Health Bureau and our aging division. So it's definitely a mix.
Gotcha. So what's the current vacancy rate at the health department?
Let me look. I don't want to tell you the wrong number, but I've got it. Our current vacancy rate is 33.8%, and most of those positions are from school health and are required by the state.
How many of those positions are that one?
Say that again?
How many of those are the school health positions?
Most of them, but I can get that exact number for you.
Gotcha. How many employees do you have in total?
We have around 700 employees, but I'll get that exact number for you as well.
Gotcha. So, because obviously 33% is a crazy vacancy rate.
It is.
So that would be about 230 positions. Yeah, we definitely want to know, is there somebody here that can look up how many of those 230 positions that are vacant are from the schools?
I don't know that you have somebody who can look that up now.
Okay.
The other thing that you have to remember about school health and that vacancy rate is that those are highly specialized positions. A lot of those are nursing and nursing aid positions. And I'm not sure if we discussed this during my confirmation hearing, but one of the things that most local health departments across the country struggle with, and Baltimore is no different, found that out when I came in here and really started looking, is that with these types of specialized positions, especially in the nursing positions, it's very difficult to compete with the market. And you all have a great health system here in Baltimore City. And we don't pay nurses at the health department working for the city what a Hopkins or a Maryland or any of the other hospitals pay. And so it makes it difficult to recruit.
Gotcha. And I think we definitely discussed this with one of your predecessors. So just to tell it to you as well, during the budget season, we spoke about this specific issue. And it's clear as day, at least to me, that with this level of vacancies in that specific position, and that's been ongoing for years, that I think it's time to like propose like a wholesale change to that program. And so let's just say, you know, of the 231 vacant positions, 150 of them are these school nurses, and you're just simply not going to be able to get them for the competitive salary. I think we'd be better off figuring out what that golden number is, right? So, you know, it's not necessarily doubling the salary per se and then taking 150 positions and making them 75, but there is a number that would take to be competitive. And I think whatever that number is, it would be very nice to see that proposed by the health department in this coming year's budget season to see how we can do that. I know some of it is state required, so there might be enabling legislation necessary, but I think it's time that we figure out what that number is, we get the salary to that number, and we reduce the positions, because otherwise, I mean, what happens with that with that money? Is it just sitting there? Because I assume you can't use it for anything else.
It has to be used for that, exactly. But I appreciate that, Councilman Schleifer, and we will definitely look into that and come back to you with a proposal on what it looks like to really attack school health in a different way.
Right, and
I agree
what that
with
salary.
We've been having discussions about that, and to really look at salary, absolutely.
Gotcha. All right, perfect. So just to clarify the committee request, Julia, the first one is to know how many exact number of vacant positions, and where those vacancies lie. And then once you provide that to us, if you could also provide what the standard salary should be and what it currently is in the school health. And then also if you can just provide the information on if that's something the city council has the authority to do in-house, or if that's something that requires state approval.
Thank you.
Thank you. Councilman Gray, any further questions? All right, well, thank you very much, Commissioner. Thank you for you and your team coming down. If you have any closing remarks, I'll give that to you, and then we'll adjourn.
Absolutely. I just want to thank you, Councilman Schleifer, for bringing me back, allowing me to share my vision, allowing me to give a summary of really has been a passionate drive to really get in here, learn Baltimore City, learn the Baltimore City Health Department, and work with these dedicated professionals. So thank you for this opportunity to present.
And thank you for your willingness to come down. So, all right, we are now adjourned.